I think the prototypical procedure in which the laser excels above other technologies would be laryngeal papillomatosis. Below the vocal folds or above the vocal folds, I think that other technologies such as shaver excision or manual extraction with cup forceps can be used quite easily. Flexible lasers and things have been used in the trachea and bronchi for these lesions. But on the vocal folds themselves, the C02 laser, in particular the scanning technology for ablation of these lesions, affords me the greatest degree of freedom for removal of the lesion and the greatest degree of accuracy to eliminate damage to the underlying lamina propria and prevention of scar tissue. I've found that the voice results, in my experience, exceed that of other instrumentation methods.
When I'm treating laryngeal cancer, I tailor the treatment to the patient and to the disease. Diseases that involve the lateral aspects of the vocal fold or the very anterior aspect of the vocal folds or the posterior aspect of the vocal folds, I feel are most easily treated with the addition of a C02 laser with the operating microscope. Endoscopically, you have a relatively small field of visualization. You can expose it with the laryngoscope in 1 or 2 positions, and you can use your operating microscope to achieve excellent visualization. Using an articulated arm line-of-sight delivery system, then you can hook up your AccuBlade micromanipulator, and using the CO2 laser in this manner gives you great visualization, relatively hands-free cutting, and then you can use your hands to suction blood if it bleeds, or to distract or to put tension on the tissue, so you're cutting against tissue.
You really can customize the way the laser interacts with the tissue to get the best possible cancer resection and provide the best functional results for the patient. Where this is most dramatically seen is in taking off cancers of the vocal cord itself.
In treating laryngeal cancer, there are a number of modalities. We recently have been looking at this and have identified nearly 100 patients with laryngeal cancer. When we looked at how we treated those patients, they broke up almost evenly, about 25% going for radiation therapy or chemoradiation therapy, about 25% going for transoral laser microsurgery, about 25% going for open partial laryngectomy surgery, and roughly 25% going for total laryngectomy with some form of primary reconstruction. The interesting thing in looking at this data was identifying the lesion itself had a great deal to do with which treatment modality we used, and patient interest as well had a significant component of that. But as we did notice we were doing more transendoscopic or transoral laser resections as time went on. However, I do believe that as with instrumentation, the technique that you use needs to be catered to the lesion and the patient. There are wonderful roles for open laryngeal resection as well as chemoradiation therapy protocols. Total laryngectomy may be most appropriate in some patients. When confronted with an otherwise healthy appearing patient and a small vocal fold pathology, I will often steer toward transoral laser microsurgery if at all possible. Balancing the voice, the swallowing, and airway results after these procedures and comparing that to results with radiation therapy, I think, is critical. And balancing the essentially downside of having long-term radiation effects versus those initial effects of surgery alone is also important. And I think that a lot goes into these decisions, and I don't necessarily think that we have a simple algorithm for identifying which patients are best for which technique yet. But we are looking into that.